My name is David Mack. I'm an orthopedic surgeon. I practice primarily out of this hospital, North Cypress Medical Center. I've been in practice out here in Northwest Houston for almost 16 years now. So at any rate, this talk I believe will probably run about 30 minutes or so. I'm going to cover what I call the top 10 common problems that cause shoulder pain. There's certainly more, but I tried to narrow it down to those that I see the most frequently. We'll start with what I'm doing now, a brief introduction. I'm going to talk for a few minutes about shoulder anatomy, just so we'll know what the shoulder is, and when we're talking about shoulder pain, what it is we're talking about. We'll move on to the top 10 causes of shoulder pain. I'll talk to you a little bit about how I approach the diagnosis of the different problems. In other words, how do we pinpoint exactly what it is that's causing the pain in the shoulder? We'll then, of course, talk about treatment options, briefly about rehabilitation, and finally, the majority of the time will be spent hopefully answering questions. So everybody knows what the shoulder is. It's the part that your arm attaches to. It's made up of 3 bones: shoulder blade, right, called the scapula, the humerus bone, and the clavicle bone. Each one of these bones has multiple parts, but essentially it's a ball inside of a socket. The shoulder is actually much more than bones, as we all know. It's encircled by a variety of muscles. Everyone's heard about the rotator cuff, right? Has everyone heard about that? Okay, so people come in all the time asking about what is the rotator cuff. I think I've torn my rotator cuff. I believe the pain's coming from my rotator cuff. And chances are you're probably right, but this is the rotator cuff. The muscles that you're seeing here on this artist's illustration are meant to depict the muscles of the rotator cuff. It's actually 4 muscles. There's a big one in the front called the subscapularis. There's one on the top called the supraspinatus, and there are 2 in the back, infraspinatus and teres minor muscles. But all of these muscles together encircle the ball and socket joint and allow us to move the shoulder back and forth, allow us to rotate it. Therefore, it's called the rotator cuff. Inside the shoulder, it gets even more interesting and more complex. There are ligaments that attach circumferentially 360 degrees around the shoulder. There's cartilage deep inside that creates sort of a lip to deepen the socket. And there's a tendon way up at the top, the biceps tendon, that connects to the biceps muscle in the arm that we're all familiar with. Any one or all of these muscles, tendons, ligaments, bones, cartilages, etc., can all cause shoulder pain, either individually or in combination with one another. And that's what sometimes makes sorting out what causes shoulder pain in any one individual difficult. But we'll get more to that in a second. So here we go. Before we start with the top 10 list, it's difficult to talk about the symptoms of different specific problems individually because they all kind of mesh together. I mean, let's face it, any one of the top 10 problems of the shoulder, can cause pain. It can cause a sensation of weakness, sometimes stiffness or loss of mobility in the arm, sometimes popping or grinding. And so just by saying that you have pain doesn't mean that you necessarily have a rotator cuff tear or arthritis. The quality, the character, the location of the pain is helpful, but all of these conditions can cause any one or all of these symptoms. And so I'm going to give you the common things that cause these problems, a little few vignettes about each one that might be specific to your individual problems, and then we'll talk a little bit more about treatment. So by far and away, I think this is the #1 problem that most people have with their shoulder when they come in to see me. There's something that's called impingement syndrome. I don't know if any of you have heard of that. How many of you have heard the word bursitis, tendonitis? Okay. All of those get thrown in together in what's been termed in the medical literature impingement syndrome. So if you look at the shoulder, there's the ball and socket once again. There's a bursa sac right beneath the bone and right above the rotator cuff tendon that's depicted in this artist's depiction by this dotted line. That bursa sac is there to provide lubrication between the muscle and tendon and the bone. So when we move our arm back and forth, it glides normally, hopefully, without pain. And when this bursa sac becomes inflamed, especially as you can see here with the arm raised out to the side or raised in front of you, you can imagine how that bursa sac would become pinched off between the bone and between the bone below and the bone above. And so this pinching or impingement can result. And so if you have this problem, typically there's not an injury. It didn't happen at a specific point in time. It developed gradually. So in other words, when you start to realize that your shoulder's hurting bad enough that you want to come see the doctor, and you think back on it, well, it might have been a month, it might have been 3 months, it might have been a year, but it's been gradually getting worse over time, and that's the way these impingement problems develop. And the reason they can develop is sometimes in response to an injury. I mean, we can fall on the arm or get involved in a car wreck or what have you, but more often than not, as time goes by, we may stop exercising in the same way that we used to, right? We may start to lose some of the strength in our arm and some of the normal mobility and flexibleness in our, or flexibility. I don't think flexibleness is actually a word, flexibility in our arm. And so what happens over time is the muscles start to contract, and as a result of that, the muscles fall out of balance. And because of that, when we raise our arm overhead or out to the side or in front of us, that bursa sac can become inflamed. So that's the number one problem, I think. If impingement syndrome or tendonitis goes untreated, in other words, if it continues for a long period of time and nothing's done to reverse the process of inflammation, we get probably the number 2 problem that most people have in their shoulder, which is a rotator cuff tear. I showed you guys a second ago a picture of the rotator cuff. Remember, it's 4 muscles around the shoulder. This one on top is called the supraspinatus, and this is by far the most commonly injured tendon in rotator cuff tears. And what can happen over time, the persistent and untreated inflammation of this bursa sac can spread and involve the tendon down below, and over the course of time the tendon can tear. And so when we scope a shoulder, put a scope in and look inside, this white stuff on the top of the screen is normal tendon tissue. This stuff down below is bone, and so this triangular looking defect is actually the tear in the tendon. In other words, this tendon part should attach to here, and this tendon part should attach to here. And so over time, sometimes due to injury or trauma, but more likely not, just due to inflammation, degeneration that's unchecked and untreated over time, we can develop tears in the rotator cuff. Tearing of the rotator cuff exposes nerve fibers, either in the bone or the tendon, that aren't normally exposed. So when we move our arm in different positions, we get pain, we get catching, we get popping, we get weakness, we can't lift like we used to, we can't swing a golf club, we can't swing a tennis racket, and all those things pile up over time. So moving a little bit more to the front of the shoulder, we're all familiar with the biceps muscle, right? The muscle in the upper part of the arm that we work out when we're teenagers to show off at the beach, right? So this is the muscle, the biceps muscle, and it has a tendon that comes up through the shoulder and attaches onto the shoulder socket. It's one of only 2 tendons in the body that goes through a joint. Another one is in the knee. But that biceps tendon, because it comes around the bone, makes a sharp corner and attaches to the socket, can become inflamed. And so you may notice this as deep-seated pain within the front part of your shoulder. You may notice it as pain when you lift with the muscles that allow you to flex your arm, the biceps muscle. You may notice pain when you reach forward, for example, to shake somebody's hand. All of those things are indicative of a biceps tendon problem, and they can occur alone or they can occur in conjunction with rotator cuff problems. So pain in the front part of the shoulder, pain reaching forward like shaking hands, pain lifting with flexion of the arm, all of those things can be indicative of a biceps problem. Okay, this is an interesting one. Normal tendon should not have any calcium in it. Normal tendon is like thick tissue, almost like leather, but it's not, it doesn't have any calcium. So if you come in, your shoulder's been killing you, hurting like crazy, and it just started overnight or just started a day or 2 ago, and we take an x-ray and we see this. Can you guys see this white dot there? That's a large deposit of calcium within the rotator cuff tendon. That's different from a tear, and nobody knows why this occurs. A lot of research has been done trying to determine why some people develop calcium within their tendons. Nobody knows. It isn't necessarily related to a high blood calcium level, and it's not necessarily related to any kind of excess intake of calcium, which would make sense, but it's not. And so what happens is, for some unknown reason, calcium develops in large concentrations within the tendon, and it precipitates. And so this is what it looks like when we scope a shoulder for this problem. You see this whitish stuff coming out. It's almost the same consistency as toothpaste. But what it does is the calcium is an abnormal material within the tendon. It causes intense inflammation, intense pain. We can oftentimes try to pull it out with needles, which we'll do in the office, and that's many times successful, but when it's not, we go in there and actually scrape it out. So this is not a low-grade nagging pain that's been there for years or months. This is a severe, acute pain that's developed over a very short period of time and really, really is a problem. But fortunately, we can normally treat it without too much trouble in the office with medications and with injections. So we talked about the bones of the shoulder. That's the collarbone, clavicle, and that's one of the shoulder bones called the acromion. And can you see that gap in between? That's a normal gap between the acromion and the clavicle, so it's called the acromioclavicular joint. And its purpose is to allow connection between our actual body and our actual shoulder bone. And it is a joint that moves, but unfortunately, like any joint that moves, it can develop arthritis over time. So what happens is, rather than being a nice clear space like we see on this picture here, we get a much smaller closed space with bone spurs, we get inflammation, and we get pain. So the AC joint is right on top of the shoulder, right on top. So normally, if we move our arm across our body like we would do, for example, to put on a seat belt, we can do that without pain. When you develop pain in your acromioclavicular joint, or excuse me, when you develop arthritis in that joint, and you reach across your body, that joint compresses, so the arthritis in the joint becomes more painful, more symptomatic, and you'll feel it. Fortunately, even though it's a common problem, we can treat it many times with just medication and injections, but in extreme cases, we'll go in there with a scope and a little tiny burr and actually shave out the bone spurs. And this is a picture of a surgery where we've actually taken out the bone spurs, and what you're looking at on the right side of this picture is the actual bone after the bone spurs have been resected. Frozen shoulder. Who's heard of a frozen shoulder? Yeah. So this is a very, very common problem that can occur alone, but many times occurs with impingement or with rotator cuff tears. And it's exactly what it means. Our shoulder over time, rather than being mobile, we can move it around in big giant circles, begins to contract and freeze up. And the reason for that, the reasons are many actually. It can occur in response to an injury. It can occur in response to another shoulder problem, such as a rotator cuff tear. We see it in people that have diabetes. We see it, excuse me, in people that have had recent surgery, say heart surgery or breast surgery. But at any rate, in a normal shoulder, the capsule or the ligaments that surround the shoulder are very, very loose. I mean, let's face it, the shoulder is normally a very loose joint. We can go around in giant windmill circles without too much trouble, but when the lining of the joint starts to become inflamed for whatever reason, that lining starts to contract. And as it contracts, the shoulder gets tighter and tighter. And some people literally can't even move their arm enough to put on their shirt. You know, women can't reach back to do their bra. Men can't reach into their back pocket to get to their wallet because the shoulder's freezing up. So what we do about that is many times we'll just do medications and physical therapy. If that doesn't work, we'll go in there with a scope, clean out the inflamed, contracted, frozen tissue, which is always very, very inflamed. This is what it looks like. It's really, really beet red, lipstick red, inflamed, angry tissue that we can remove, free up the shoulder so that we can start moving our shoulder again and the pain goes away. Instability. So this is something that we see a lot in our younger patients, our athletes in particular. Sports that require large ranges of motion, baseball pitchers, are notorious for developing instability of the shoulder. Swimmers, big giant arm movements when they do the freestyle or any style for that matter, backstroke. Volleyball players, tennis players hitting overhead. Anything that requires very large ranges of movement, forceful blows with the arm, can develop shoulder instability. So what can happen over time is the ligaments or the cartilages or both that inherently stabilize the shoulder can stretch out or even tear, and you develop pain. You develop pain because the ball and socket isn't working in sync any longer. Because the ligaments that stabilize it are now stretched out or torn, as you move your arm, as a baseball pitcher throws a pitch, or as a swimmer reaches for the wall, the ball may slip with respect to the socket and cause pain because now you're stretching on muscles and tendons and ligaments that shouldn't be stretched. So that's a problem that many times we can treat successfully with physical therapy to tighten the muscles. But when we can't, we have to actually go in there and physically reattach the torn muscles, or I should say the torn ligaments, back to the shoulder socket. Slap tears. So this is a little bit, we're getting into some more esoteric stuff here, but at the top of the shoulder, as we're looking at the socket end on, remember we talked earlier just a few minutes ago about a rim of cartilage that goes all the way around the socket to deepen it. The very, very top, where our biceps tendon comes in and attaches to the shoulder, we can develop tears in that area that have been termed SLAP lesions, and that stands for superior, labral, anterior to posterior lesions. So this is superior, meaning the upper part of the shoulder. This structure is the labrum, and it tears from anterior to posterior or front to back. So this can occur from a variety of things. It occurs commonly in our athletes. Our throwing athletes get this all the time. It can occur from a fall on the shoulder, suddenly compressing the joint, like when we fall directly on our side. It can occur from sudden forceful pulling on the arm. For example, you're climbing a ladder and you lose your footing and you fall down and your arm hangs on the upper rung. Any of those things can cause tearing of the labrum. This wasn't recognized until relatively recently. I mean, this is something that's really become a hot topic in orthopedic surgery. And what you have to do more times than not, this isn't something that generally heals on its own. Once we've recognized that this is the cause of your pain, we'll go in there and clean it out and put sutures in it to repair it. Osteoarthritis, okay? Everybody's heard of arthritis. Osteoarthritis is the most common arthritis. It's the wear and tear arthritis that we get in our knees, in our shoulders, in our hips. And it's something that we don't see commonly in younger people. We get this as a result of degeneration and aging over time. So many times if you come in to see me for shoulder pain and your age is 60s, 70s and on up, this is one of the things that I may think of because this doesn't happen in a 20-year-old. But what happens over time is this normally smooth cartilage surface of the ball and of the socket can degenerate or wear out over time, sometimes due to injury, sometimes due to previous surgery, but more times than not just due to simple degeneration, which can be genetic. In other words, if your father or mother or brother or cousin or aunt had arthritis, you're more prone to developing it. So what we see on x-ray is here's the ball and here's the socket. I think you guys can appreciate how there's very little space between the ball and socket, just a little sliver. And we see these large bone spurs, this little hook down below, both on the ball and on the socket. We see these little cysts in the bones, and we see how white the bone is. All of those are indicative of arthritis. And so this causes pain, it causes stiffness, it causes loss of mobility, it causes creaking and grinding in the shoulder. And aside from medication, there aren't many alternatives than to actually go into the shoulder and replace it, like you see here in the lower right-hand corner. This is a shoulder replacement with an artificial metallic ball and a plastic socket. A lot of people will come in and say, doc, my shoulder hurts. But this is the shoulder, but they're feeling pain, up in the neck. So when we talk about shoulder pain, there are things other than shoulder problems that can cause pain into the shoulder. And one of the more common things that causes that is pinched nerves in the neck. So this term cervical radiculitis, cervical just means neck, and radiculitis just means inflammation of the nerve that goes down into the arm. You'll typically feel pain, not necessarily in the shoulder itself, but more on the side of the neck or in the top of the shoulder, up in these muscles here. If you look very closely, I hope you can see this. This is an MRI scan of somebody with a herniated disc. Do you see this black sort of blob in the back there? Can you guys see that? Well, this gray structure coming down is the spinal cord. These blocks here are the bones of the neck. These black oval structures in between are the discs of the neck. Here's the front, here's the back. This would be the person's mouth and nose. This would be the back of their head. And right there is an enormous herniated disc. Well, you can imagine that if this disc slips out towards the back and starts pushing on the spinal cord, as we see down here, the nerves that go down into the arm can be pinched and cause lots of problems. So just a heads up, not all shoulder pain is actually due to the shoulder. We'll talk a few more minutes just about how I go about making the diagnosis of what's causing shoulder pain, or shoulder problems. Like we talked about at the start of the talk, everything causes pain. So I would typically ask you questions more about the pain. Location, where does it hurt? Or duration, how long has it hurt you? When did you first notice it? What's the quality of the pain? Is it an aching, dull pain? Is it a sharp stabbing pain? Is it a burning, tingly pain? All of those things mean different things to me. And how bad is it? I mean, is this just sort of a mild nagging thing that your wife made you come in for, or is this something that's keeping you up at night, keeping you from going out, playing with your kids or grandkids because the shoulder pain has gotten so bad? So we have a number of things that we can do in the office just based on physical examination to determine what's causing your pain. We bring the arm up in front of you is indicative of many types of rotator cuff problems. We can push and actually touch the part of the shoulder that's painful. Could be your rotator cuff, it could be your AC joint, it could be your biceps tendon, it could be a lot of things. We'll take an x-ray almost always. X-rays are normal in many, many shoulder conditions aside from arthritis. So if you have a rotator cuff tear, if you have biceps tendonitis, if you have shoulder instability or a slap tear, all of those things are not going to show up on an x-ray. But sometimes what we'll see is we'll see small bone spurs forming off the shoulder bone, which can be indicative of developing rotator cuff tears or developing impingement syndrome. We can see arthritis at the acromioclavicular joint up here on top, and we can see arthritis developing between the ball and socket, and all of those things are helpful. So normal x-rays don't necessarily help us make the diagnosis, they just help us rule out a lot of things. What we do in the office that's very, very helpful, and this is something relatively recent, is we do an ultrasound. Everyone's heard of ultrasounds like women have for babies. There are lots of medical indications for ultrasounds, but we have a specific musculoskeletal ultrasound machine that we've begun using over the last year or so, which helps us actually look deep inside the shoulder, past the skin and past the muscles, beyond the bones and into the tendons and rotator cuff area to see what's going on. So it only takes about 15 minutes or so to do this. It's relatively inexpensive, it's completely painless, and it's been a great adjunct to our practice to be able to do this. So what happens is, if you're having shoulder pain, we examine you, we think we know what's going on, but we're not exactly sure, your x-rays aren't particularly helpful, we'll likely recommend when you come into the office right then and there, an ultrasound of the shoulder. So we'll squirt a little bit of the ultrasound jelly right on the shoulder and put the ultrasound probe on, and we'll get a picture very, very similar to this down below. So this is the actual humerus bone. This whitish colored structure here is the rotator cuff. This is the skin way up at the top, and this is the space where the bursa sac would be in between. And we can tell really amazing things about the shoulder. We can tell from an ultrasound whether you have a rotator cuff tear. We can tell if you're developing a rotator cuff tear, you might have a partial tear. We can see fluid around your biceps tendon. We can oftentimes see the labrum, the cartilage that causes slap tears. We can see a lot of things with this. So this is very, very helpful, not only for diagnosis, but also if we determine that an injection might be helpful for you. The ultrasound allows us to put the needle exactly where it needs to go so we can treat the source of your pain. MRIs are very, very common. We do these all the time now. It's difficult to see a doctor, at least an orthopedic surgeon these days, and not get an MRI scan. I hate to say that, but MRIs is such an amazing technology. I mean, you saw the picture of the ultrasound, right? I mean, let's face it, it looks pretty cool to me, but it probably looks pretty fuzzy to you. I mean, that doesn't look like anything too exciting, but you get an MRI scan, and look how clearly you can see the bones. Look how clearly you can see the cartilage. This happens to be a labral tear, a slap tear. Look at this. This is the rotator cuff. Look how beautiful you can see the muscle and the tendon coming out to the bone. In this particular case, this is the torn edge of the rotator cuff. This end of the cuff should actually be attached down here to the bone, and all this white stuff in between is fluid, so this is a very, very large rotator cuff tear. That's what the MRI machine looks like. So if you come in, we do an x-ray, we do an ultrasound, things aren't looking like we really are getting all of the information that I need, I'll oftentimes send you for an MRI scan. It takes about 45 minutes of your time, but it gives amazing information in terms of diagnosing the problem and assisting me with treatment plans. So here we go. So when you have shoulder pain, we've sort of narrowed it down to the top 10 things that at least I see that cause shoulder pain. What are the different options for treatment? Many times we'll start with an anti-inflammatory. That would be the over-the-counter brands such as Aleve or Advil or Motrin. There are a whole variety of prescription brands of anti-inflammatories that you may have heard of or seen advertised on television. Celebrex, for example, Relafin, Lodine, there's a whole bunch of them. Shoulder, more than any other joint, I think, will do injections for because, number one, it's very, very accessible. It's very easy to get into the shoulder with a tiny needle for an injection. It's also very effective. I mean, if you have inflammation around your biceps tendon or if you have inflammation in your bursa sac causing impingement syndrome, we can deliver a small amount of cortisone injection directly into the area that's inflamed. We can use our ultrasound machine to do that, and the pain may go away, and that may be the last time we ever need to see you. So that's something that you might expect if you came in under the right circumstances. Physical therapy is a cornerstone of treatment in shoulder pain and post-operative care. Ron in the back can attest to that. You know, all of these things can cause pain, but a lot of them also cause weakness and muscle atrophy and stiffness. And until we can work through some of those issues, the pain's never going to go away. So our physical therapists are definitely the stars of treatment in a lot of these problems. And of course, the last resort is surgery. Many of these problems do well, many of them don't. And when they don't go well, we have to end up doing surgery on them. This is a picture of a typical ultrasound injection, ultrasound-guided injection. We'll use a small syringe, a tiny needle, and the ultrasound probe to help us get it in the right spot. Physical therapy, there's Ron in our sports center treating somebody with shoulder pain. So there are lots of different types of surgery. Many of these conditions can be treated with arthroscopy, fortunately. So in the older days, before arthroscopy had been developed, if you had shoulder pain and you had to have an operation, it would mean a 6 or an 8-inch scar on your shoulder. It would mean peeling the muscles away from the bone. It was very dramatic stuff. I mean, the outcomes were very good down the road, but there was extensive surgery involved, days in the hospital, extensive rehabilitation, and so forth. And fortunately, during my career and my experience, arthroscopy has taken over and become really the mainstay of our treatment for most types of shoulder problems. So arthroscopy simply means, arthro means joint, and scopy or scopy means scope, so we put a scope into the joint. And so that's about the normal size of a typical shoulder arthroscope. This is a person's right shoulder. This is the back of the shoulder. This is the front of the shoulder. We can make tiny little 1/4-inch incisions and put the scope in. The scope then, through fiber optics, projects the image of the inside of the shoulder onto a video screen that we can look at, and we can use different tools from different smaller portals around the shoulder to access the problem inside the joint. So it's really remarkable what we can do nowadays with a scope. Here's a picture of the inside of somebody's shoulder. This was a rotator cuff tear that had torn off the bone. We use different types of sutures to actually pull the rotator cuff tear back and repair it to the bone. This is a slap tear. We talked about that a little bit. This is the biceps tendon, the labrum that comes around. This is the upper part of the labrum that's torn with a small metallic probe showing the defect. We can put 1 or 2 or 3 sutures in that and tie it back down. This is a picture of an instability repair. If you've dislocated your shoulder, you may have torn the ligaments off the socket, and that's what's represented here by this sort of dark defect between the ligaments and socket, and we can put sutures into the bone all through a scope and tie the labrum back down. After surgery, I think surgery is the easy part. I mean, it's the part that I do, but I think the real work comes afterwards, and that's where the whole team that's sitting in the back of the room really helps out. Most shoulder surgeries take an hour or 2, sometimes longer, but that's just the tip of the iceberg. After surgery, there's a lot of rehabilitation that's involved. My practice is almost exclusively knee and shoulder problems, and I can tell you just from experience, knees are hard enough, but shoulders are difficult. So not for me, but for patients. Shoulders are difficult to rehab. It's a more complex joint. There's more anatomical variance between shoulders. There's a lot more going on. So whereas we can scope your knee and you're back to playing golf within a couple of weeks, the same isn't always true of the shoulder. So I'm certainly not trying to be pessimistic in any way about what we can do with shoulder arthroscopy and shoulder surgery, but just a realistic reality check that shoulder surgery on Thursday is only the start. It requires generally 6 or 8 or 12 weeks of physical therapy, exercise, and time afterwards before the shoulder starts to turn the corner and feel well again. We use a lot of different sorts of techniques. We use many times a sling after rotator cuff surgery or labral surgery to protect the shoulder so it's not injured when you're going to the grocery store or going to church or going out shopping. Holds the arm next to the side. We'll oftentimes use something called a CPM chair. This is an actual motorized device that helps us move the shoulder in different directions to prevent scar tissue. And aside from that, our physical therapists are very, very helpful. So that's just a brief introduction to shoulder pain. I hope that was somewhat helpful. This is a new talk that we've added just in the last couple of months, so I'll be refining it, hopefully based on your suggestions. And I thank you very much for your attention. I appreciate all of you coming out, and it would be my pleasure to take any questions that any of you might have. So thank you very much.